Okay. It's a little bit late, and thank you for staying and listening to us. This is a great presentation you have had from our speakers, and please, we're going to do this way. Just if you want to ask a question, be very brief, or comment, whichever way it is, and identify which of the panelists you want to ask questions. So I want to start by asking, since I have the mic, let me start asking with a big question to our speakers. Thank you, fellows, for great work. The title of this talk or this session is the role of economics or health economics in decision making. So, if you have only 5 minutes with the governor, how would you explain the role of economics to decision making, given what you have presented, particularly to Kim and Karen? How would you explain that? Yeah.
I feel like this is a thesis defense.
No, it's the title of our section.
Yes, that's right. I don't think that, the short answer is I don't think that I would need to explain that to any kind of government. I think that these countries very much feel the pressure and the constraints that are financial, economic. I think that the value that the work that Karen and I and Mark and you, the role of evaluating economics and decision making is to be able to, to project what we might expect to be the future burden and economic health of the country, how an intervention might look great today and might look very valuable and effective, but really in the grand profile of all interventions, really there needs to be a prioritization because we are dealing with countries that have constrained resources. So I would just try to emphasize the value of the type of work that we do, not just on cost effectiveness, but really trying to project longer term outcomes in order for planning and for, just trying to be efficient with our limited resources.
Excellent.
Right, and I think I'd like to add to that and just say that, economic evaluation is one of the important cornerstones of decision-making in policy evaluation, but it's not the only thing that policymakers consider, of course. I mean, cost-effectiveness evaluation gives us a formal framework to compare strategies with each other, and it can be a very useful tool. But it's for good reason that oftentimes the willingness to pay threshold is called an indicative threshold, and what that means usually is that there's actually quite a degree of flexibility in there for decision making so that other factors can come in. So for example, for screening interventions, we need to think about the practicalities, for example, of increasing colposcopy referrals by more than half under some strategies for primary HPV screening, even if that's theoretically cost effective. Or for male vaccination, for example, considerations, for example, of equity have been invoked, as well as considerations of cost effectiveness. So I think it's just one of the planks in the evaluation, but it can be a very useful one.
Thank you. Audience, please. Identify yourself and briefly where you're coming from.
I'm Matt Pillsbury.
Can you come to the mic, please? Yeah.
My name's Matt Pillsbury. I'm a consultant. I've been working with Merck on their HPV modeling. And one of the things that at least we've seen in our modeling that can really sort of have an impact, but doesn't necessarily come through in a lot of what I've seen of the literature, is adherence and the assumptions you make around adherence. Because the HPV vaccines are 3-dose courses. A lot of times, I mean, especially in the U.S.
Are you making a comment, or actually?
I'm getting to the. I just wanted to clarify.
Be brief. Okay.
Yeah. Especially in the U.S., the adherence is poor. You get a lot of people who only get 2 doses or even only get 1 dose, and that assumption really can affect your cost effectiveness, both because, if you're assuming that it's mostly effective still, that that's one thing, but otherwise it's wasted. It can be sort of wastage. So how is that, I mean, how would you address that? And I mean, especially you, yeah.
You who? You, me?
Yeah, I'm sorry, Dr.
Kim, yeah.
We're all like...
Sorry, I meant Dr.
Mark, who's the
no.
moderator, would like to answer. Well, you know, I would say that, first of all, there have been some analyses. We've done some analyses in the Gavi-eligible countries. The problem at this point is that we're still waiting for the data to really emerge around 2-dose and 1-dose in terms of longevity. That's really an important caveat to any kind of assumptions we make on less than 3 doses. But absolutely, you know, I think more and more we're trying to reflect the actual compliance adherence. We do that with screening. Perhaps if you look at the technical appendices, you know, you might be able to dig through and find what the assumptions are. But I think that in terms of, you know, I know that I'm familiar with the work of the folks up here, and we've all found that coverage and those things are very important in terms of impacting the cost effectiveness. So I think that we've been pretty cautious about trying to document our assumptions and look at that variable.
That's right.
Did you want to?
Okay, well, I'm sure Mark will expand on this, but I think that really raises the important role of really careful connection to the available literature to inform our assumptions, and really careful calibration of our models, and really careful sensitivity analysis, and look at scenarios under which combinations of assumptions might change our decisions about cost effectiveness.
Particularly the area of sensitivity analysis, which is what Karen just mentioned. Yeah. David, yeah.
Well, more from an immunization point of view, I think what is really important is to have different scenarios. I think, you know, that a particularity of an immunization program is that you really have good indicator of accomplishing some targets on coverage. So I think it is very important not to see reality as what the only possible scenario, but really to have a scenario where you have high coverage, because you would expect, and we would expect in Latin America over a few years that you really can get up to very high coverage. So I think it is important, you know, not to settle for a 60% coverage, but really to have different scenarios where you can actually compare what will be initially in the first year and what could be after 2 or 3 years actually of the introduction.
Mark, you want to say something?
I think adherence is important, but when we're looking at the cost effectiveness, I think that even without herd immunity and when we vary coverage, these vaccines, the HPV vaccine in girls is highly cost effective. So I'm not too sure if it really changes the actual conclusion, unless a lot of young girls have maybe one or 2 doses. But I think that our conclusions are quite robust to that assumption. There are many other things in our models that that are more uncertain.
Thank you.
Yes. Dr. Dwara, yeah.
To Jane and then to Tania. Jane, I noticed that the price of the overall price of vaccination, I mean, your graph with you varied from 10 all the way to 100. And then in parentheses, you had the price of the vaccine, each one. Why are they correlated? Shouldn't they be independently consider the price of delivering the vaccine versus the price of the vaccine per se? Now, this would be a question for you. What's the rationale? And for Tania, the threshold, I mean, the Gavi puts that threshold for defining what it would be a Gavi-eligible country. And then eventually within those that are eligible, it seems to me that there is a counterintuitive approach of giving them a high bar for meeting what your standards are. For instance, delivering, I think, 70% of DTP and all of that. So what about countries that are truly in the bottom of the Gavi list?
So I'll start by addressing that. We were looking at that analysis from a payer perspective, but irrespective of who's paying. So that cost of delivery on top of the dosage cost, on top of everything else, we consider to be an important factor when determining the cost effectiveness, because somebody's got to pay it. It's a cost incurred by perhaps not Gavi, but the country itself. It's a measure, and it's not really about like the money that gets exchanged. It's really, cost effectiveness is really about the value of a resource. And we measure that value by cost.
I just didn't see the logic of being correlated. Why would the two different prices be correlated? The price of the vaccine plus the price of the delivery? Because the number in parentheses was correlated with the number you overall.
Oh, there are some fixed costs. So the program costs and the administration costs. So it isn't always, I mean, we have graphs that show the breakdown of the different costs, but there are some fixed costs that don't vary by number of dosages given. So that would,
Right.
sorry, I misunderstood.
Sorry, on this previous question, I think the point is that you cannot vaccinate without incurring the operational costs. So I don't see how they could do the analysis just focusing on the vaccine price or on the operational cost price.
My question was, why were they correlated to be the example?
Okay. All right. On the thresholds, so the GNI is really about focusing on the poorest countries in the world, and I think you're clear about that. On the DTP3 coverage, the reason why we have that threshold is that that's the proxy we use to ensure that the country has a sufficiently strong immunization system so that they could take up other vaccines like pneumococcal, rotavirus, or HPV. So if the country doesn't have a strong immunization system, it would be worthless to support them spending own resources or Gavi resources into trying to introduce a vaccine that they wouldn't be able to introduce effectively. Now, I think what you're asking is what do we do with countries that have a DTP3 coverage below 70%, and for those countries what we're funding is we have a window that is called health system strengthening, so we're funding their health systems so that we can strengthen their ability to support immunization. So for instance, funding training of human resources, cold chain and so forth, so that they could actually reach the 70% DTP3 coverage, and then they can be funded to introduce more newer vaccines.
Okay. Yes, you can.
I have a question. It's something I've been thinking about with the Gavi initiative. The vaccines are being available for very poor countries. And then there are the richer countries that can actually pay for the vaccine. And then we have this great vaccine. It's really cost effective. And if we're health economists, what we do is we calculate the price that the vaccine can be for it to be cost effective. But we forget one thing, and that's ability to pay. So then there's this divide between the poorer countries that can actually get the vaccine and the richer ones that get the vaccine. And then you have these middle-income countries, and we saw that figure. So what are your thoughts regarding this issue about the middle-income countries? And what are they to do with a great vaccine, but because it's good, the price can be asked at a high price. So it can be for.
So that's a very good question. I was a couple of weeks ago at a strategic advisory group of experts advising WHO on immunization, and they actually did show great graphics about very high coverage in rich countries. At this point, very high coverage in Gavi countries, and we have this big gap in the middle of middle-income countries, and the coverage there is actually quite low. So I mean, I guess the answer from Gavi's side is we are asked to focus on the poorest countries of the world, so that's what this is the tier of countries we're going to focus on. But we are working to also help introduction of these vaccines in richer countries. And what we can do, because some of these countries were formerly Gavi eligible, is really to focus on the Gavi graduating countries. So now 57 are Gavi eligible, and they were previously 72. So those countries, they are called graduating countries. And what's happening is that a lot of the companies are agreeing to keep the Gavi price for the graduating countries. This has happened, for instance, in the case of pneumococcal vaccines. We have this procurement and funding mechanism that is called advanced market commitment, and that allows for all the Gavi, the former Gavi eligible countries, so all the 72, to have access to $3.50 price for pneumococcal vaccines. The difference is that the countries are asked to pay for the full price. For HPV, what we've done is, as as we issued the tender recently for the Gavi eligible countries, we also asked companies to quote a price for the graduating countries. So we have to see the results of the tender. They're going to become public very soon, but that was our attempt to help.
I'm not really sure. I think what is important, I have the impression that many times we misunderstand the costs given by a cost-effective analysis as being a fair cost. And I think that is really a misunderstanding, because we should never negotiate the price down from something or up from something else. So, and that something else to me will really be the cost of production, recognizing as well the R&D investment, and probably as well a fair, return on the investment for that. But I think, we always tend to negotiate down from somewhere when we should actually negotiate up from something that is really what, the vaccine costs to the producer in a sense. And, given that we need to recognize some income to the manufacturer as well. So I think, it's a key issue that I think we have not really been able to address to the moment.
Yeah, Maarten Schim van der Loef from the Netherlands. I've got a question for Dr. Canfell. Thanks for your talk. You said in kind of a byline that if girls get better vaccination coverage, then at least heterosexual men are covered as well. And that's all completely logical. But implicitly, you're leaving out a small but important group of people, gay men, who won't benefit, and they are actually the group of men with the highest burden of disease of HPV-induced cancers. So I was wondering if you would like to comment on that one.
Our paper does deal with the issue of the potential for targeted vaccination of MSN and the general issues of accounting for disease in that subgroup. So it was just lack of time for not dealing with it in the presentation. But I think there's a couple of issues here. First of all, there is at least the potential for some herd immunity even to MSM if they have, if they are not exclusive MSM. But for simplicity, the cost-effectiveness evaluations of male vaccination reported to date have mainly modelled MSM. And I believe Mark's group is actually reporting at this meeting on a new model that includes MSN in their population as well as heterosexual males. So I think that will be a significant step forward in the cost-effectiveness evaluation of male vaccination, and will let us really move forward so that we can be sure that we're accounting for disease in that subgroup. So maybe you'd like to comment further.
Okay, the issue about cost effectiveness in MSM is that that population, the MSM population, is around 3 to 5%. Although the burden is very, very high in the population, it's very difficult for a model to show cost effectiveness of vaccinating all boys to protect men who have sex with men. And so for even when we include MSM within our model, it's still not cost effective when coverage is very, very high. So then we have to look at other strategies such as targeting MSM, and that's what Jane did in one of her papers.
Just wanted to add one caveat to the previous work. And a lot of those cancer rates are actually, so when we pull the cancer burden for males from cancer registries, that's not stratified by MSM or heterosexual. So you're capturing, in your cost effectiveness analysis, you're capturing the reduction in the burden, maybe not differentially for the MSM, but still capturing reduction in potential reduction in cases in that population. So it's not to the exclusion of them, and we just haven't looked, we haven't modeled them separately and modeled the transmission of HPV in the differentially higher rate up until now. So it's not entirely true that they are completely excluded, because their cancer burden is reflected in our estimates.
You have a follow-up question?
Their cancer burden is reflected, but they are left out of the positive benefits of the vaccination strategies, isn't it? Because Because how could gay men benefit from women being immunized, even if some men also have sex with women?
I'm sorry, this is predominantly a question, I think, in relation to vaccination of young boys, potentially before they're identifying.
Okay, I see. Okay,
Yes.
good. Sure.
Okay. Any other questions?
I would have one last one.
Okay, good.
Because
I wanted to take one.
I think people are very curious about how decision makers actually use our results, and maybe just briefly, not how if you had 5 minutes to explain something, but rather, which I tried to answer a question like that and I wasn't able to at the last meeting, so I try not to answer those questions. But I'll try to ask the question in another way, is that when you have time to talk with the decision makers, what is their experience with the results? Because I think a lot of people are skeptical of the real use of these cost-effectiveness analysis.
Yes, yes.
For me, I found a range of reactions. Either high skepticism is one extreme, or complete ignorance and bliss, and whatever you're doing is great, it's black box, I don't understand it, so I love it, and I believe everything you say. Neither one of those extremes is particularly good in my mind or productive. Usually, when I've done work with the CDC or American Cancer Society, it's a long process. I mean, you know this, we've gone through this. It's a very long process of iterative discussions, really going under the hood of the models and trying to explain. It's important for us to have the ability to communicate at a level that doesn't bore people to death on what the important functionalities of our models are, as well as what the results mean in English, not English, whatever language you speak, but in common language. And so that's a skill that takes a long time to, I think, acquire, and we're always trying to work on it. I think with every partnership that we've had with decision makers, it's a new learning process, but I think thankfully they're willing to have us at the table, which has been a really wonderful experience.
Right, I agree with that. And I think in our case, our model is actually that a lot of the work that we do is actually commissioned by screening programs. So that's really useful because that's really working together to get to the final answer on cost effectiveness. So often the strategies that we're evaluating are guided by advisory panels, and the assumptions that we're using in the models are sort of fully ratified by the decision makers in the country. And I think that even if that process takes longer, which it does, and it sometimes takes us several years to get through an evaluation, it's really a good way to bring the decision makers with you and have good buy-in to the final answer.
I guess I'll make a comment to that. Just to say, as a non-expert on the subject matter, that indeed I think one of the main issues is the difficulty to understand. If you think of decision makers in many of the GAV-eligible countries, for instance, I think that there is really a limited availability of experts that could digest this type of analysis. And also one point that Karen previously made is that this is only one of many considerations into a decision to then introduce a vaccine or not. Another important consideration is affordability. So if you think of Gavi-eligible countries, for instance, the first thing that comes to mind is this is a Gavi-supported vaccine, i.e. my cost is 20 cents per dose. It's affordable. While for other products that are maybe more cost-effective, if there is no support from an international agency, then it's not affordable and I'm not going to introduce the product. So I just think we need to be aware of the realities on the ground and to take those into account to then really propose even more forcefully the importance of cost-effective analysis and make sure that there is an understanding of the benefits.
The only thing that I can add probably is the question that, with this vaccine, HPV vaccine, there is inherently another layer of difficulty, which is to explain it when the other vaccine is for a much shorter time horizon, if you want. So I think, for HPV, it's really difficult to explain this. because you have a much longer time horizon many times that you have to do. So I think what is really important is as well to put these more specific economic analysis within what will it represent for the development of a country. And I think, in that sense, for many countries, it's really important whenever you make a significant public health investment, how it will actually as well contribute to the development of the country. So I think, in that sense, it is really important to put a cost-effective analysis within a much broader concept or background of what it is really the return of investment over a long period of time.
Well, on that note, we end this section with a very interesting, dynamic discussion. Please let's congratulate our panelists again, and thank you for listening. Bye.